the meeting started. We're going to be beginning the February 14th, 2024 Monterey County Emergency Medical Care Committee, and we'll start with a happy Valentine's Day to everyone. Just a quick announcement before we start getting into the items. If it's okay with the committee, I would, after we do roll call and introductions, I'd like to move item 7A, which is a recognition, next into the agenda before we do public comments. So that's fine with everybody? Okay, we'll go ahead and do that. And Steve, if you'll do roll call and
good morning.
After.
Welcome, everybody. Going to do, I know you guys have signed in. We'll do a real quick roll call. Will Hiller?
Present online. Mike is going to be sitting for me today.
Very good. Thank you. Sam Klemick? Chief Jim Lamborg?
Here.
Harry Robbins? Jody Schaefer?
Here.
Nancy Utterback?
Here.
Paul Wood? Here. Nick Greenson, who's
Remote.
sorry to- I see him. He's online. Thank you. Go back to our paramedic rep. Nope, I don't see him. Okay, Carla.
Yes, here.
Or the building, apparently, sorry. Chief Workman? Here. John Anthony. Alternates, Mike Lesslinger.
I'm here.
Cheryl Getz. Ben Harvey, Noah Hawthorne, Joe Cafaro. And Andy Smith.
Here.
Oh, Joe, perfect, thank you. Okay, ex officio, Kelsey Scanlon. Teresa Rios. I see her online, and Leanne Magoski.
Here.
Wonderful. Want to do guest introductions? We can do that, but they don't have to say. No one. But basically, we're asking if, as a guest, if you'd like to introduce yourself, but there's no requirement to do so. Unless you speak to an item on the agenda.
I'll introduce myself. I'm Clay. I'm with Active Transport Medical Services. We actually operate an ambulance service out in Merced County, Stanislaus County, San Joaquin County. Myself and my business partner established that back in 2017. It actually became an ambulance service. We originally provided non-emergency medical transportations like litter van services in Merced County. And then in 2019, we became an ambulance service. And so here we are now and still surviving and prospering. So we'd like to try to bring our services out to Monterey County if possible. And that's why I'm here today.
Hi, I'm Leslie Oliver. I'm the new Emergency Communications Manager for Monterey County Emergency Communications in charge of fire.
Good morning, I'm John Ray Hassan with Royal Ambulance, or a regional ambulance provider based out of San Leandro, about 850 employees, 120 ambulances, service the majority of the Bay Area with BLS, ALS, and CCT services. Appreciate the lens of reaching out.
Sam Ballanteri, retired EMT.
Scott Houchin, retired.
So happy.
Okay, let's, it's a great introduction there, Scott. Let's move on to item 7A, and we'll turn that over to Teresa.
Okay. So I'll actually take that for Teresa since she's being remote. And we've had an EMS recognition program started under a previous medical director, Dr. Jim Stubblefield. And it's fallen off a little bit. COVID really, made it hard to gather and do the recognition that we like to do. So at times things come to our attention for people who should be recognized. And so I'd like to start off with Stephanie Nosita Apperson as our next person that we would like to recognize. And I'm turn this over to Dr. Burley for the recognition. I will say, because it's been a while since we've done this, a couple of things about the program. We really do work hard to vet the folks who we recognize, because we want them to be people who are, very much examples of how we want people to, our EMS providers to function, to do, and to be the people we would say, look at them, be like them. We've got a couple of items for the people who we recognize. One of them is a certificate, which Dr. Burley will present. And it says something about the individual. And they've done close probably to 100 of these people over the years. Every single certificate is unique to that individual. We've not recycled any language. So when you get one of these, it's yours and it's about you. So with that, Dr. Burley, if you'd like to. And Stephanie, you gotta come on up here somewhere because you gotta hand it to you.
That's it.
Excellent. Well, thank you, Steve. Appreciate your words. And Stephanie, the EMS agency wanted to recognize you for receiving the Star of Life, very prestigious award. A lot of hard work went into it, and the medical care that you provide to the residents of Monterey County is all the better for it. So once again, congratulations from the EMS agency, and we are presenting you with this plaque as well as a challenge coin and pin as well. So thank you so much. Now that I give you all these things to hold, congratulations. You got to get a picture, of course. There we go.
So
I started working with Stephanie when she was a brand new EMT and have known her throughout her career. She is a shining example of what we want in EMS.
Thank you. Thank you.
I'd like to add I'm just gonna add a couple of things real quick. You'll notice on the pin, on the pin, in really small letters, so if you're like me, you definitely gotta wear your glasses. At the top little border, there's some tiny letters that spell out excellence. And a few years ago, we gave a very similar pin out to everybody who was part of our system, but they did not say excellence. So these are very much an earned recognition that we hope you will wear proudly. I know AMR has allowed this as an item, for the uniform. And then, of course, she got a challenge pin or challenge coin with her name and position on it. It's engraved. It's yours.
Oh, wow.
Yeah, we've spared no expense, right? It's really quite, we want this to be a very prestigious honor, to receive. And now, Mike, you have something to say actually about stuff.
Yeah, I just wanted everybody to know that for those who are not aware, the Star of Life is actually awarded by the American Ambulance Association each year. And I apologize, I didn't come prepared or anything. But it's really, in EMS, in private EMS, I think the 2020 National EMS Survey stated that there was just over a million EMS caregivers licensed in the United States. And each year they honor typically only about 300. So it's kind of like in EMS, it's equivalent to winning an Oscar. I mean, it's really a pretty major award. So to have, Stephanie and one of our local caregivers honored in that way, it's really, really significant. I mean, it's the type of award that, when you fulfill your EMS career, it's really the best award that you could possibly receive. And high level, I mean, I'm sure that you got to meet with some senators, and it's a very, very high profile award as well that, everybody, I think it's just really great that we have somebody locally here honored with that. So congratulations.
Thank you.
She may have got a very prestigious award from the American Ambulance Association, but I'll bet she keeps the challenge coin with her.
Keep it on you. I know the rules.
All right, thank you.
Thank you.
Our next recognition, I've asked to do this one. I've known Scott for over 40 years, and we want to recognize Scott Houchin because he he's recently retired and it's created a bit of a gap in EMS in Monterey County. I remember him when we were brand new, relatively new. I'd been working LA County and Orange County before I came up here to Monterey to work. But he came out of ENT class, came to work with us in Monterey for Peninsula Medics, went back to A1 Salinas, came to work in Santa Cruz as a paramedic. Then started teaching at Hartnell College, has been teaching at MPC. Been a firefighter, EMS person at Salinas Fire, provided training all over the county. I honestly don't think there's anybody who hasn't been touched by Scott in some way who's an EMS provider. Either directly or indirectly, because he's been to all our committees, he's been a true champion for EMS. And so we've created a plaque for him to honor him on his retirement, to say thank you for all you've done for us in Monterey County. So Scott, come on up. I want to read what we've written for you. Okay, so with great appreciation, the Monterey County EMS Agency recognizes Scott Houchin. In recognition of your many years of service in the County of Monterey and giving your heart to EMS through service as an EMT, paramedic, EMS instructor, firefighter, and mentor. There are few who have impacted more EMS professionals. You leave a legacy that will continue to live in those whom you have touched. And I just want to say thank you for all you've done, and I appreciate all your efforts. And I know your heart's been genuine, and so this is for you.
Thank you very much.
Thank you.
You know, it's been a privilege to be able to work in a system I grew up in. I did my best, everything I tried to do, I put my heart into. And the opportunities in EMS are really tough and challenging. It evolves constantly. You know, I'm grateful for having a great team here that I got to work with. My family supported me through this whole adventure. It was probably 15 years I wasn't home. It just takes a toll, but this is greatly appreciated, and thank you so much. You know, I don't have any more words that can really express how I feel, but thank you.
And in case you're wondering why he's not getting a certificate and a coin and a pin, he already has one. He was one of our first people that we recognized back in 2010.
Thank you, sir.
Thank you, Scott. And you guys are welcome to stay through the rest of the meeting if you wish, but we did it early so you could gracefully slip out if you'd want to.
Okay, we'll get back to the agenda here. Moving on to public comment. Any members of the public wish to address the committee for a period not to exceed 3 minutes on any issue not on the committee's agenda?
Sorry. Congratulations.
See any online? Okay.
Thank you guys very
Approval.
much. I'm off to the kids' school for another.
Approval of the past EMCC meeting minutes. We're going to be looking at both September 13th and November 8th, and is a single motion on that appropriate?
That's fine.
Okay. Entertain a motion for approval.
Since Harry's not here.
I know. I'm gonna have to change my notes.
I move we approve the meeting minutes. I was not here on November 8th, so I don't know if I can make that.
Did you read them?
Did you read
I
them?
read them. I read
Did you
them. They
watch-
look good,
did you watch
but I
the-
wasn't here, so.
Did you watch the video? Okay.
I can make the motion. I was here for a while.
Okay.
In
Well-
fairness, Charles McKee would always remind us that you don't have to be present to make the motion.
Okay.
Oh, nice.
Well,
You don't have to,
yeah,
I mean, you don't have to abstain either.
everything I read in the November 8th meeting minutes looked good, so.
Okay.
Anyway.
Carly,
And I
just second.
All in favor?
Aye.
I'm good with that.
All right. Moving on to reports, EMS Director.
Thank you. So During our recent CCC meeting, I believe that was on January 10th, we had some presentations. One was from Dr. Searles Quick, the Director of Crisis Psychiatry at Ohana. And Ohana is a new program that is in close proximity to CHOMP. And they have some services that they offer for youth experiencing psychiatric crisis, including prevention services, outpatient clinic, as well as a partial hospitalization program and an intensive outpatient program. So these are all sort of levels of continuum in the care of pediatric patients in crisis. We received lots of information about that, as well as information regarding their crisis stabilization unit, how that works. In general, what we learned is that these patients are going through the emergency department, getting medically cleared, and then being referred to Ohana. Currently, these patients are at CHOMP. There was some discussion in terms of whether other hospitals within the county might be able to transfer those patients. And although this is something that is being looked at and considered currently, we don't have an avenue for that. So that was just a little information that we received on their presentation. We also heard some information from Monterey County's critical incident stress management team, the CISM team, in regards to mobile crisis and their ability to respond to the scene of an incident and provide support and resources to patients who may not necessarily need to go to the emergency department. And in some cases, the resources that they provide may be more appropriate and save an emergency department visit. So we got some information there. We are still, since it's such a new program and in development, we are still in dialogue with them regarding working out all the nuts and bolts of the program, how their teams will interact with EMS. And so not all the pieces are completely in place, but we do have an upcoming meeting with them in March to further discuss and coordinate. So, the Tri-County initiative for buprenorphine has been going well since its inception through a local optional scope of practice. There has been some discussion among the various counties in the Tri-County initiative of following along with what many other counties are doing, which is providing an opportunity for EMS to treat patients in opioid withdrawal without requiring consultation with a physician. So currently, under the policy and protocol, if EMS is going to administer buprenorphine to a patient, they contact a physician, discuss the case, the physician reviews, and then gives the order. This can be helpful, but also it can be sometimes a hindrance to patients getting medication in an expeditious fashion. And so throughout the state, counties are looking at removing the requirement for direct physician contact and making it a standing order. Dr. Hearn, as you know, has been instrumental in educating physicians and EMS agencies throughout the state, and he will be delivering a learning collaborative on February 27th from 1 to 2. If anyone's interested in hearing more about this initiative, and Monterey County is looking at it as well. We haven't made a specific decision, but that's something that's on the agenda. I think those were the primary things that I wanted to just report back to this group. If you have any questions, I'm happy to answer.
Okay. EMS Director, Ops.
Thank you, Chief. There's nothing to report for ops. The last meeting was canceled, and we had a joint meeting in November, so there's not much activity going on in ops right now.
Okay, and then while you're there, anything for EMS agency report?
I didn't prepare a report for this meeting because one of the agenda items is an update on the RFP. So I wanted to focus on providing the committee with a good report on the RFP.
Okay, very good. Mohawk, Deborah.
Yes, so we have been working to strengthen the relationships with public health emergency preparedness and the hospital preparedness program in particular that we started to build during the COVID response. We've been participating in a lot of group events with them. So working with the Healthcare Coalition, which is a joint coalition with the facilities and skilled nursing facilities, long-term care facilities in both Monterey and San Benito County. Last month, we had a presentation from the region on facility evacuations that had quite a bit of useful information. We also participated in a tabletop with the Association of Bay Area Health Officers related to regional emergency response, and then an election security tabletop as well. Probably our most recent activity was the response to the 2024 winter storms. We were a part of the EOC activation and played a role in coordinating resources and communications with long-term care facilities in particular that were in the area impacted by the power outages. So quite a bit different role than we played in 2023, but we had about 20 facilities to coordinate with that we communicated with regularly. And we're able to get some resources such as generators and blankets and things out to those facilities that were experiencing the power outages. And I will put a plug in for another upcoming tabletop exercise related to active attackers. This one's coordinated by the Bay Area Urban Area Security Initiative. It's specific to Monterey County, and it's going to be taking place on April 18th from 8 a.m. to 4 p.m. here in Salinas. Would encourage all of the facilities to identify an emergency management related person and a base hospital coordinator or similar position to participate in that. And then all of our EMS agencies, fire departments and the like to participate as well. So there is a flyer that went out related to that, but please feel free to reach out if you need any additional information. And that's all I have unless there are any questions.
Very good. Okay, moving on to EMS system performance metrics. Kimberly.
Good morning. The communication testing for 800 megahertz and ReadyNet were included in your agenda packet. Everything was pretty status quo for the months of October and November, which are the ones we're reporting on this time. The only thing to note was that there was quite a dip in the 800 megahertz response from Me Memorial. We did identify that there was an issue with their 800 megahertz phone, which has been corrected since then, and everything's been going well. Any questions on the communications testing? Okay. Can I go ahead and jump into the next one? Okay.
Yes, please.
The next one is there's a PowerPoint included in your agenda packet for ambulance provider contract compliance. Quickly, I'll go over that. Again, we're reporting for the months of October and November. All priorities that were calculated for compliance or met the 100 call rule, met or exceeded 90% compliance. And I'll take any questions if anyone has that.
The only question I have is I know last year you were able to do a report where you separated out the data into the different regions of the county. Is that something that we can do again in this calendar year?
Are you referring to the South County jurisdiction?
Yes.
Okay, so we are currently working on that. We have shown it to contract compliance working group, and we'll be able to give an update in March on when we may be able to bring it to EMCC.
Very good, thank you.
But real quick, that we just kind of glossed over that, but that's a big deal. That's so much better than it was, last year.
They've been doing quite well for the last 12 months, really. I mean, here and there, they'll dip to about 89%, but in general, it's been doing very well, their contract compliance.
I agree.
Thank you.
Excellent. Okay, moving on to old business. EMCC reappointment. Steve.
Okay. So we're going to get started a little earlier this year for the committee members and reminding you that some of you, your position on EMCC is going to expire. And I brought a staff report for you, and I think I'll look at it. Sure, because I'll just let the members know which ones are expiring this month. Or this year, we have expiring Jim Langborg, Carla Spencer, Paul Wood, Nancy Utterbeck, Spencer Harnett are the members who are expiring. I'm gonna take one and pass it down. The alternates that are expiring are the ones with the same position. So we have Cheryl Getz, Joe Cafaro, Noah Hawthorne, city manager alternates open at the moment. So is citizen rep, and then Andrew Fife, who we've received his information. We'll be pushing him forward as the alternate for the paramedic position. So those are the ones. I'll be sending this out as a reminder. So what we need from the members is a notice, letter, email, whatever, that says that the organization that you represent is interested in having you continue to be the representative. Oh, and Joe Cafaro is the hospital rep. Don't want to forget her. That they're interested in having you continue as either the representative or the alternate. And if your bio has changed, because we will include the bio, please update your information, get that to us, and then we'll submit the nomination for continuing to the Board of Supervisors and get the appointment done. Now, we need this done by June 30th. So if you don't want to continue to hear from me at the meetings and emails and phone calls, please get this done early. We can get you guys nominated and approved by the board and move forward. With that, we are also looking for citizen rep alternates. I know Harry, and I think I can speak for him, he's been doing this a long time. And he'd like to have somebody replace him. So we do need alternates, and we do need people who are thinking, hey, maybe I could do this. And then when Harry's ready, he can step aside. So if you have people who are unaffiliated with any of our EMS providers that are interested in serving, 6 times a year, and then reading, of course, the meeting materials, please send them to me, and we can share with them what the position entails, their requirements, and then move forward and get them on EMCC as an alternate. So thank you very much. Any questions, especially from members?
Steve, I do. So I think we have an EMCC meeting in May. Would that be correct?
We have March and May.
Okay, March and May. So should we have this targeted to have these recommendations in by that May meeting? And because is there any action that needs to happen on behalf of this committee in time for June 30th?
No, there's really nothing this committee does. It's the Board of Supervisors. So the March meeting would be great to have everything. It's just a tickler for your mind to get this done, because we do have to go through the whole board approval process. So we do need a little lead time. May meeting would be the final, where it'd be easy for us to move everything through, but we don't want to be last minute. I'll put it that way. So the earlier the better. We'll just move it to the board, and you can have your name in the board agenda along with your bio. So we'll move forward.
Okay, and then I would just recommend keeping this as an old business item, and just with an update in each meeting subsequent, so that we're staying on top of it.
And yes, there will be emails coming from it.
EMS ordinance revision, Deborah.
Steve,
Yes, ma'am.
so what would help out for timing purposes, for at least for me, I hope maybe perhaps other people, is that if there is like a drop dead date deadline on when you as the system needs to have the name in the bios in so you could work through your process, so we could work backwards on that date? Could you please let us know?
Probably May 30th will give us adequate time to get everything together and on the board agenda. That's a real rough figure. Go ahead,
May I
Teresa.
jump in? I would do it the beginning of February. I'm sorry, the beginning of May, because it can take 4 to 6 weeks to get items on the agenda. So, and then after that, you still have to do your OSO's office. So we want to backtrack that time. We start giving notification in the March meeting to make sure that for those individuals who are nominated by their organizations, that we get those letters in. The ones that are appointed by me, like the citizen reps, then we can speed up that process. But for like the fire representatives are nominated by the Fire Chiefs Association, we try to give them ample time because they do take them to their association meeting, and then they send us a letter nominating the different individuals. But for me, 2 months is really what we need to be able to get it done, because it's not just getting it to the board. It's also making sure that your oath of office is in our position. Without the oath of office, then you're not officially seated on the board, on that committee.
Okay. May 1.
Very good. Okay, EMS ordinance revision, Deborah.
Yes, we took a resolution to the Board of Supervisors in the month of December. And this was related to health and safety code updates and issues that are required to be considered in any contract for emergency ambulance services. This is will be part of the update to the ordinance as well, but we wanted to have it in place a little earlier due to the RFP being issued soon. We are continuing to work through other topics and draft language with County Council, and hope to wrap that draft up soon. So I'm happy to answer any questions on it.
Here, no questions, thank you. Health data exchange, Blake.
Good morning, everyone. Update on our health data exchange process. Our last meeting for the health data exchange group was back in December. We had to cancel our January meeting just due to the holidays and people being off. So there wasn't too much to report at that time. For those of you who aren't familiar with the health data exchange program, it is a program where EMS providers and hospitals exchange data on patient information. And from our last report that we gave at the clinical care committee meeting, the current steps that we're looking to take right now as the EMS agency is we've been holding meetings with ESO, our PCR provider. And they've described a program that might be able to assist us with our HDE program called EMPI. The difference with this program being, whereas HDE requires hospital numbers, or it's called a chart or a counter number, to make a match on a patient's PCR, and then information can be exchanged to the providers on a patient outcome report. The EMPI system, it bases off of the patient's information and demographics. So you name, date of birth, things of that nature. And hopefully to help with providers receiving more data and more information on their patient care. We have received a quote from ESO on that, and we'll working on an internal discussion on the next steps on whether we'd like to approve the EMPI or if there's any more information we need to reach out to ESO on. Along with that, our other topics that we're going to be looking at is releasing training materials and some memos for the stakeholders, which we hope to have released soon. And part of the HDE program is we continually update the CQI tag committee with the newest developments. And then we hope to also shortly be sending out to our EMS providers daily ESO outcome reports. Basically, this would show the number of patient care reports that actually have an outcome report attached to it from the hospital. and we're looking at the percentages of that. And we hopefully will have that published here soon. Our next meeting is actually next week on February 20th, which is Tuesday. And that is what I have to report as of right now. Any questions on the HDE program?
Apparently not. Thank you, Blake. Ambulance RFP, Teresa.
Thank you, Chief. I'm gonna share my screen. Can everybody see the PowerPoint?
We're good.
Yes.
Yes. Okay, awesome. Okay, so the purpose of this item is to update you on to where we are on the progress of the RFP. So just as a way background and to remind everybody what the priorities are for the next ambulance contract and some of the challenges that we face. So our priorities, of course, are to select a competent and reliable provider for 911 ambulance services, to identify a means to meet the system needs, for example, interfacility transports, and there are others. This interfacility transport is a hot item right now, so it was the first one that came to mind. And then to provide the best possible value for patients utilizing the EMS system. Now, in our challenges, that we face, we are balancing the sometimes competing needs of stakeholders. We are facing increasing costs in the setting of shifting payer mix. At the last meeting that we briefed the committee on the RFP, we talked about some of the challenges and how the payer mix has shifted. We have geography and response times, pockets of density that can also be challenging, like the Big-Sur area. And then we have added cost of providing services. In our system, of course, the ambulance provider handles the dispatching of the ambulances, and they do the call interrogation of the calls. We have the unplanned events, standbys, and out-of-county transports as part of our challenges. So where we are right now is that everybody knows we released the scope of work, the draft scope of work for public comment. In addition to that, we held several public meetings to give everybody equal opportunity to comment on the scope of work. And that was before the deadline of submitting written comments to us. One of those meetings was a joint meetings of our committees, EMCC Ops and the new CCC, former MAC committee. After those meetings were done, we also presented at the Fire Chiefs Association. So the stakeholders and members of the public were given opportunity to comment on the scope of work. The comments and questions received through the series of public meetings and via the written submissions are being reviewed. We received nearly 170 comments on the draft scope of work. Let me just clarify that those are not unique comments. Because people attended more than one of the meetings that we held, the comments were repeating. And in some cases, we received comments from different entities that were, sometimes verbatim. So it was the same comment, it was just submitted by different entities. Some of the general comments or themes were innovation, flexibility, and transparency. And there were specific comments that addressed a variety of topics, which in the next slide, we're going to review some of the topics that received the greatest number of comments. So interfacility transports received the highest number of comments, the greatest number of comments. There were 25 comments related to interfacility transports. Of those 25, let me just say that 19 were general comments, nothing specific, just, you'll see on the comment summary that I will go over. And then 6 of those were very specific to behavioral health IFTs. So on the comment summary list that you see there, we listed some of them, and we wanted to point out that the stakeholder input that we received shows 2 conflicting viewpoints. The first 4 bullet points that we see is they want us to require the contractor to provide long distance transport. to ensure the contractor continues to have the obligation to make the medically necessary behavioral health transports, and to add language to provide service at the level requested by the transferring MD in the time frame requested, and that the provider should be able to manage response at multiple levels, ALS, BLS, CCT, crisis response team. On the flip side of that, we received comments that say that the burden should not be put on the ambulance provider of the EOA, that there should be a standalone RFP that can meet the specific needs of various hospitals for behavioral health patients, CCT, and specialty care, to allow other providers for IFT. Some of the general comments is to clarify overload language, to better tracking of mechanisms for IFT. You get the meaning there. So for us, it's difficult to balance what is being asked of the system when we have such conflicting points of view. Provision of IFT, for example, the IFT services at the level requested by the hospitals, which are the first 4 bullet points where comments that came from the hospitals, they do impact the 911 system availability. You know, there's only a limited number of ambulances in the system. Each time an ambulance is taken out to provide an out-of-county, particularly out-of-county transport, it takes the ambulance out of the system, and that ambulance is not available for the next 911 call. The cost of the level of readiness desired by hospitals is like, we want them to handle all the multiple levels. We want them to come when we call them, and they need to be responsible for everything. That impacts the rates paid by patients throughout the system. And then we are tasked with balancing, mitigating competition for 911 services with maintaining availability of transport providers for IFTs, while at the same time, finding a way of minimizing the impact on the rates. So you can see why this is not an easy task for us. Tied into, this is part of the IFTs, but this critical care transfer received a comment, so we thought we highlight what those were. On the comment summary, what we heard is that there's a need for CCT resources despite the low volume, and but at the same time, there should be actions for flexibility. They want appropriate CCT staffing overlap to meet community needs. They are telling us that there's a need for innovation to avoid reliance on air crews as backup for inadequate CCT staffing. On the flip side of that, also, we received comments that say for us to separate CCT service from the ambulance contract, or to contract multiple contractors for CCT and behavioral health. So again, this is another example where the input received shows very conflicting viewpoints. We're at 2 ends of the extreme. And requiring CCT resources from the contractor at the level desired by hospitals will mean higher rates for the patient. We are currently evaluating different delivery options to maintain CCT service despite the financial challenges, losses incurred by the current system. I wanted to take a minute to talk about our efforts for EMS system design, especially as it relates to IFT. At the November meeting, we heard from everybody, and some of the comments were that, and you saw some of the written comments that says, we need to be innovative, we need to be flexible. We didn't do enough, we gave you the same old scope of work. I wanted to put this slide here just to show you some of the efforts that we have made. We want to effect change in the system, the right change. But when we find ourselves in the middle of 2 conflicting viewpoints, it makes it difficult for us to come up with the right mix, if you will, of the services that will meet the needs of the patients of the county, but also minimize the cost to them. We were hoping that through the public comment period that some specific ideas would come up. Unfortunately, that's not the case. What we have done, based on the feedback received and the call for us to do better, we have reached out. We are trying to get more information, get some additional input specific to this issue from the hospitals. And so here, I just want to review some of the things that we've done in terms of system design. So our current model is an all-inclusive ambulance service provider for all 911, IFT, and CCT services. We are not required to include IFT and CCT. This contract from 2010. Supposed to do that. It was good because we had a provider responsible for all of the IFTs, regardless of where they went. But providing those services, particularly out of county IFTs, have become more challenging, as everybody knows. Not as many facilities that will accept these patients. They can be resource heavy, particularly for the longer transports. And then the increased cost for the readiness, the capacity to provide all services, cost has increased for everything. And it's also true for the provision of these services. What we have with this model is that it leaves no options for the hospitals, as nobody else can provide IFT in an exclusive system. So once we set up an exclusive system, that's it. We can, undo it. And since I started getting involved in some of these issues before I was even the director, that was one of the things that we kept hearing, particularly from the hospitals, that there are no other options. Especially when there are delays in response to IFT requests from the hospitals, then the system can get bogged down. And that can happen several times a day, as all of you know. So we went to the drawing board and started looking at, well, what could be some of our options. So just wanted to give you a flavor of some of the things that we have been considering, and even running by the hospitals to see, where is the happy medium, if you will, that we can reach. So some of the models that we have discussed is the current model, which is not sustainable. We have discussed 911 ambulance services with all in-county included, in the right of first, in-county and out-of-county included, but for out-of-county including a right of first refusal. We also discussed a 911 with all in-county included, and limited out-of-county IFT with also a right of first refusal option there, with all other out-of-county IFTs being provided by permitted ambulance providers. That process would have to be established for the permitted providers. Another option is a 911 within county IFT and all out-of-county IFTs being provided by permitted providers. A 911 system only. So that would mean completely removing interfacility transports, which is, the feedback that we got from some of the fire agencies, that, this needs to be taken out of the 911 ambulance contract. So that's all in county and out of county interfacility transports to be provided by permitted providers. And with CCT, we have discussed to include them with an option with some kind of hybrid model of having. Right now in our current system, we have a dedicated nurse, not a dedicated ambulance, but just a dedicated nurse on call 24/7 to respond to CCT. We have looked at maybe doing some kind of hybrid of having a nurse, but also adding a paramedic CCT program, so that there would be more individuals who can handle calls. Of course, there's a limit to what a paramedic CCT can handle, but we are looking at all of those options, including, could we have a tri-county collaboration with Santa Cruz and San Benito, who do not have these services included in their ambulance contract, and also the other end of the extreme, excluding them from the EOA, as we have seen the feedback they have received, all in or out, that puts us at two ends of the extreme. I'm going to jump back to some of the topics that had a lot of comments. The next one is the protections for the current workforce. We heard a lot from the paramedics, EMTs, and also the union for them. That topic received about 15 comments, and what they want is protection of incumbent workforce should the RSP result in an award of the contract to a new provider. And they also want us to clarify some language. Here's an example, provide the criteria of clean and safe area when we're talking about rest areas, adequate, clean and safe rest areas for the crews. We, the EMS agency, recognize the value and the knowledge and expertise of incumbent workforce, and of course, we would like that, the protections that they're asking for there that we understand. We have to consult with county council on appropriate language. There was a bill. I only know it's a bill. I don't know the section now. It's, I think, 438. They have language that related to this area. So we are consulting with county council to make sure that whatever language we do end up with that ends up in the RFP is consistent with whatever the changes in the regs happen as a result of that bill 438. And then, of course, county council and contract purchasing have to look at this issues from a liability or risk perspective. Clinical requirements received 10 comments. I think most of these comments needed clarification on, for instance, clarify the use of bundles of care, that terminology. They actually wanted to receive the comment requesting to remove the clinical standards as a compliance measure and to only include as a tool for system monitoring. Comments on specific components of the clinical scorecard. So we are, what we know is that the clinical standards are an important measure of system performance and health along with response time compliance. The standards that we included were identified through a variety of respected EMS organizations and sources. The system is also designed to recognize the clinical excellence through a potential discount towards the response time compliance. So we want to not just monitor, but we want to have some compliance requirements. We want to balance that by, good performance. Then if there are any penalties due to not meeting response time, then they could be decreased by meeting the clinical scorecard. And we have seen that more consistently on more recent RFPs. So we're working on making doing updates we made updates to the clinical scorecard metrics and other language. We are in the process of reviewing those. Dispatch services received 8 comments. The primary one that we picked up was that the call taking responsibilities, for example, the EMD of the call is not generally the responsibility of the ambulance provider. It is an added burden and cost that would have to be factored into the patient charges. They're asking the county to consider a separate funding source to provide this service. They've requested information to help develop financial models, which of course it will be provided when we release the RFP. But what the EMS agency response to this is that we recognize that the provision of EMD adds some cost to the contractor, resulting in higher cost to the patient. It is part of the complexity of our system, and it is a cost that is currently built into the patient rate. So it would not be a new cost added to a rate that is not in place now. Even if County Com did have the capacity to assume the responsibility for EMD, the system is user supported through fees and would still require financial contribution from the contractor into that part of the system. The current model in place allows the contractor to maintain control over its portion of this portion of the operation, and I think it increases efficiency. And the last bullet is that we are working on obtaining that requested financial information, but it will be released once the RFP is released. We have some questions regarding response times that had a comment. As you can see, they want the clarification on some sections that talk about response and compliance in relation to community response times. We sought to have language similar to what exists in the current contract that says that no area of the county should be underserved. And so we were trying to find the best way to incorporate that so that we look, Chief Lambert today reminded us of the reports that we present to EMCC related to response times in certain areas of South County that are the areas that are more challenging to serve. And so we were trying to address that. So we are going back to look at the language that we crafted and see how we can give the clarification needed. They were asking us who the anticipated representatives of the Contract Compliance Committee. We mentioned that committee in the draft scope of work. And that committee is the same as the existing Contract Compliance Working Group. We just used a different name, but the membership and the function remains the same. There's questions about, not question, but a comment about allowing to utilize the peripheral service providers. I think that, you know, there's, we have to look, as I think what they're asking here is to expand the use of the peripheral service provider to any area of the county. That has its own ramifications. We have to look at that a little further. And then let's see, the 60-second shoot time is aggressive. They want us to consider 120 seconds for responses at night. And we're looking at that to see what we can do in that area. Other topics that receive responses, we're not going through the same summary as the other ones. We wanted to focus on the ones that had the largest number of comments. But just to let you know, we had comments regarding clarification on priorities. We went back and we realized, yeah, you know, some of the language can be confusing. So we are looking at that. There were questions about the rate adjustment, particularly about the formula that is being used. It said that it wouldn't keep up with the increasing cost. We are consulting with the financial analyst we have on contract in our other consultant to see what changes we can make in this area. APAT. It was more about, you know, the policies, APAT related policies, which just went in place, and we're in the process of developing policies that will be consistent with the new regulations. Some questions about training, the transition period. In particular about that is that our well-intentioned attempt to give a 12-month transition period that is too long and that it could have a detrimental impact on the system. We talked to different individuals and are making the changes accordingly. Partnerships was an interesting one. Not a lot of comments about partnership, but it was more general, you know, that we should allow partnerships. And of course, you know, we want to foster a good working relationship among all the members of our EMS system, our stakeholders. And so nothing in the scope of work prohibits partnership. We didn't get anything specific about that, so we don't know how to proceed there, other than to say that, you know, partnerships are welcome. I think they happen even today. And I think each suggestion has to be reviewed individually. So that we know how to proceed. But yes, you know, partnerships are not, we're not trying to get in the way of that. Some questions around standby services. I think more than anything in terms of reimbursement. Ambulances, it was more about the types of ambulances, wanting us to require a certain type of ambulance. That is not something that we've done. I think it gets tricky where we move too much into the operations of the ambulance provider. And so that's an area with both council and contract purchasing that will seek input, advice, and to make sure that we are not moving into gray areas there. Community equity, I think it was more about some definitions. So we're looking at those. There was a couple of questions about the use of BLS, if it was going to supplement the system, and yeah. So I think that in this case, what it looked like maybe something we were not very clear. We're going back to clarify language. And there was comments about the maps being old. The maps that we included in this scope of work, they were the current maps. We are working with our GIS, county GIS department to update the map. So for sure, the new maps will be included with the RFP. Let's see. Oh yeah, the one last comment is that there were about 15 comments covering just general topics that range from, hey, can you add pages to the RFP? We want transparency, we want flexibility, we need innovation, and some related to compliance provisions. All of those are being looked at. I didn't list here the ones that had just one comment, but there were not that many. This covers pretty much a good 85–90% of all the comments that we received through the comment period, and those were captured from the public meetings that we had, as well as the written comment that we received. So our next steps are going to be to continue reviewing our responses and drafting responses or modifications to the scope of work and the exhibits as needed. County Council and Contract Purchasing will review the revised draft and provide further comments and edits. We will incorporate the feedback from County Council and Contract Purchasing, and then after that, once we get the blessing, we will submit the RFP to the state for the EMS authority for review and approval, and it will be released as soon as they approve it. I'm happy to answer any questions you may have.
Teresa, I have one. It's sort of a question and a comment. As I was listening to this, and I apologize for not addressing this in my comments, but looking at the information that you presented made me think about this, and it had to do with the IFT and the CCT transport. And I think particularly in the South County area, and I realize that the whole system doesn't revolve around us, but we have something that's in between, and it's that prison. And what it typically means is they have medical professional staff on scene, not just EMS personnel, but they have medical professional staff in that facility. My understanding is the majority of the time, then they call, but I believe it's treated as like a 911 call, not necessarily as a inter-facility transport call. And it may not be appropriate depending on the circumstance that it would fit into that category. I guess I'm just throwing it out there that I think that is something to consider, because it does, and I realize that it reaches outside of the contract as well, but it can impact it, and it definitely impacts the system. And I'll just leave you with a real life situation that we faced a couple of weeks ago. And that was 4 calls went into the prison, within a short period of time, as well as in other South County areas. We ended up with back-to-back calls, and our closest ambulance was Fort Hunter Liggett. And I know that we do have a mutual aid agreement with them, but just that's kind of extreme, I think. And so I just mentioned that I think there's kind of another category in there, and medical clinics might fall into that as well, where you have medical staff on scene, and how we address that and how that fits into this. And that's it. Thank you.
Thank you, Chief.
I can ask a
I
question.
don't know if Michael or Kimberly, who know this area better, want to comment on Chief Lambert's comments.
Yeah, I
I
mean,
can phone
go
first.
ahead.
Go ahead, Mike.
You go ahead. I'm not gonna go for an answer.
Go ahead, Kimberly.
Okay, hear me?
Yes.
Okay, so regarding the prison, we all know that it can drain the resources in South County. Dependent on what's going on with the patient, I will say, we'd have to run numbers on it, but they are treated a little bit differently because there are medical personnel there. So it's not necessarily treated like a interfacility transport, but I will say that like the majority, and again, we'd have to run the data on it, get downgraded to a code 2 response. that doesn't mean that, you know, you would feed several code 2 ambulances into the prison. But the majority of if there is a doctor on scene, they downgrade it code 2, depending on what's going on with the patient. But of course, there's certain instances, like if the patient's having a stroke or an MI, or if there was a trauma, they're going to upgrade the ambulance to code 3. So I mean, it is treated similar to like a clinic setting. So that's done through the EMD process. So if there's a clinic setting or a doctor's office, anytime there's medical personnel with a patient, it is treated a little bit differently through the EMD process.
Yeah, I think your comments are well stated. You know, certainly the prison has a pretty significant impact, you know, on the system. And also I think that just some of the general procedures around the prison, you know, with our personnel responding in, you know, I think that there could be some, you know, discussion and review as far as, you know, how we intercept patients. You know, in some cases we, you know, go into the clinic, but in other cases, you know, we're going onto the yard, we're going into a lot of other situations that typically take a lot of time, oftentimes waiting, so our on-scene times can be really extended as well. So, you know, it's a really complex issue. You know, I can tell you that, you know, for all my years in Monterey County, we have went to the prison multiple times. We've met with the staff. We've tried to work through a lot of those issues, but we continue to have, I would say, you know, every month, significant issues, concerns, everything from concerns with safety to just, you know, how they're actually intercepting and receiving their patients. So, I mean, I would almost go on a limb to say that, you know, it could be kind of an independent review of, you know, it's almost its own mini system in a way. But clearly, you know, there's a very high population out there. I've heard it, you know, exceeding 20,000 or something. So it's a mini city in its own right. And yeah, absolutely. But it's definitely got some complexities with it that I don't think it's an easy issue to address, but certainly one that is, you know, it's more, I think, even kind of a subcommittee to look at.
I agree with that. And I think that also fits into like unit hour requirements and, you know, factoring in that population and the demand that it puts on the system, if those unit hour requirements should be considered or updated to reflect that. And it would be interesting to see what a 5-year or greater trend has been in terms of call volume coming out of that prison.
Just real quick, as the person who receives a lot of those people out of the prison, you know, the training of the prison staff is highly variable, to where there's sometimes some very competent people that you're on the phone with, and sometimes the ALS ambulance crew provides a much higher level standard of care, in my opinion. So whatever we're going to do with that, I would be really careful. I would encourage us to be super careful, because I think that there's a lot of undertrained people there.
Any other comments?
I just have thank you, Teresa, for that great information. And I'm wondering if we can get a copy of the slide deck?
Yes, of course, the slide deck can be made available to everybody. I'm really hoping to be able to generate more discussion, and particularly, you know, as we see how we have received comments, very opposing points of view, and then we are stuck in the middle. And we are being asked to be flexible, innovative, all of that, but how? One, I think that we should recognize the challenge. How do we give a system what it needs when, on the one hand, we hear give us everything, and on the other hand, we hear cut this and cut that. They don't even belong in the 911 ambulance contract. You know, we want to do right by the residents of this county. We want to do right by the stakeholders in meeting the needs. We hear. We know where the perspective is coming from. The hospitals needing beds, the hospital needing to move patients out of beds, all of that. And then hearing the other side where a system may be taxed. And, you know, we also hearing from the hospitals about the delays and wanting more options. So we are trying. I hope that the slide that shows all of the different models that we have entertained shows you that. We're not sitting back idly at our desk, just, I don't know, doing nothing. We are actively looking at ways that we can make the system better for everybody. But that is very difficult because, yeah, we could ask, I think Dr. Burley put it very well in our November meeting. We would love to give you an ambulance at every street corner. Our system cannot support that. And with increased costs, especially post-COVID, we have to be very mindful of that. The more that we put on our system, the more that it's going to cost. And then it's going to get to a point where our residents are not going to want to call 911 because they're going to want to avoid that ambulance ride, because it will break them. So I am banking on the fact that all of us here are passionate about what we do, that we are true to our commitment to the residents of this county, to doing the best that we can do for the patients that we serve. And as much as I don't like to say it, but how much is going to cost them to call 911 and get that ride on the ambulance to the hospital, it is something that we have to factor in. Again, we want to give you options that we can give you. We want to include services that we can include. We are really trying our best to find the right balance to this, and we are seeking your input. I mean, we started this process last year with the many opportunities to provide input, public meetings, seeking even from members of the public, and then this group who are our experts in EMS. Everybody's been asked to provide your ideas, especially specific ideas. Those would have been very, very helpful because, we want to be innovative, but like, how do we do this? When one's saying, give me everything, and the other one is saying, no, take it out. Doesn't belong here. We're going to continue for the time that we have in this phase of the pre-RST phase, if you will. We want to continue working with our stakeholders as much as we can. As you know, this is a process that can be very strict. So, but we want to give answers. We want to give develop the right scope of work that works for our system. But we need the input, and we want the specific, more specificity, I think is what we were looking for on that public comment. A lot was said, but the specific ideas, I think is more what we were looking for. So thank you for allowing me the opportunity to provide you this PowerPoint presentation. I hope that the breakdown of the topics that got the highest interest from our stakeholders, is helpful. And instead of bringing you all of the comments, we posted it on our website. We sent it out. It was a lot to digest, but we did our best to try to condense everything and group things by topic, especially because of all that repetitiveness. Again, different people attended several of the meetings, and at each meeting they would voice the opinion. Of course, it's a critical issue to them, so we understand. And so we needed to just kind of sift through all of that and condense it and bring it down to a little more basic and just really topic and just how much interest that topic had. So I hope you found that helpful for this meeting. And thank you for your time.
Teresa, it's Carla. Can I ask one question? In terms of next steps, do you have sort of like a timeline, or when those certain things are going to happen, roughly? Well, speaking.
Yeah, as you know, we have some meetings with hospitals to discuss this particular issue. It makes it difficult to say because we've had a number of meetings, and we are not close to coming to a consensus. We're not asking to approve a program, but for us to decide what are the sacrifices that we are going to need to make, what are the things that we can live with. So we didn't want to rush the stakeholders, but the clock is ticking, and we want to wrap this up ASAP, frankly, so we can move to the next phase of this, and is really just to craft the final language of the RFP. What we want is to be able to have the parameters that we can include in that scope of work, not a specific program again. In the draft that everybody commented on, you saw that in some cases we are asking the provider, tell us how you will provide service in this area. And then the final language will be crafted once we receive the proposals, we review, and we may need to enter into some kind of negotiation. So we're not prescribing the program. We're just saying these are the things that we are interested in, or that we would like. So I know that there was a little bit of miscommunication, and so we're not seeking that. But yes, so ASAP, we would like to wrap it. I don't want to give a timeline because it's difficult to do, especially where we are in terms of the discussions. But we really need cooperation. I think that if we can all do our part to realizing that none of us is going to get exactly everything that we want. And then again, keep in mind, the EMS agency is stuck in the middle. Certain people or certain groups want everything, and others say, don't, leave it out. So how do we come to that quote unquote happy medium?
I have something to say to that, if you don't mind. I know the RFP, the whole process is very political. AMR runs a business, they got to make money, they need their cut. They have to have their runs in order to pay their payroll, to keep their equipment healthy, to pay their insurances. There's a lot of other counties that are experiencing the same issues as this county. And we operate in a few of those counties. Even if you were to allow the IFTs, the CCT, the BLS, the ALS, it has to be profitable for another company to do that. So you can't bring them in and only give them a small fraction and expect them to be successful and to provide that quality patient care. So you have to keep that in the forefront. You have to remember that. So separating the IFTs in other counties has worked. You vet the ambulance companies, make sure that they have all their insurances in place. They're hiring EMTs, brings more EMTs into the county, possibly. So it's a balancing act, but it has to be good for both sides. Just something to think about.
Thank you for your comment.
I can make a comment as well. I don't want to say anything appropriate as being a potential bidder, but I will say that I recognize and appreciate the work that goes into it. We've been through it a few times before, and I will say that, it's a very fiscally fragile system. There's a lot of complexities to providing services in Monterey County, which I would say that in some cases are a little bit interdependent. Especially when you look at things like, payer mix, all of those elements. But, the only thing that I would throw out there is that, I recognize that, there's a lot of frustrations over the years with response times and some of those things. And my only ask, just, from being both a resident in the county and also being the provider, is that, you take into account all of the complexities in providing those services, everything from dispatching, CCT, all of the elements, because what you don't want to do, and this is kind of my biggest ask, is that if you just create a wish list as an RFP, you're going to end up with a failure. And I think that, you're squeezing a balloon, basically solving one issue and creating another. So, I think that there's probably going to be some compromises and just kind of working together to figure out the best ways that we can provide services, leveraging all of the EMS partners in the system and figuring out, how best to provide those services. So, it's been a tough situation. And I've worked in a lot of different counties from Alameda County. I spent, 3 or 4 years up in Santa Clara County recently. And, I will say that everybody here has a lot to be proud of. it really is a great EMS system because in most other systems, not all of the EMS needs are being served. And I think that, when you look at all of the elements, we don't have the same APOT time issues that they have in other areas. So it's a complex issue, but that's just my big ask that, everybody try not to create a wish list, but rather figuring out, how best to serve all those needs in a reasonable way. But also, the costs and the finances are always the elephant in the room. And I learned a long time ago, that's something that we should never be afraid to talk about because, those being fiscally, stable allows us to provide services, as you say, buy the right equipment, make sure that we're providing livable wages to our staff and, our personnel. So it goes a long way. So anyways, that's my 2 cents.
I agree with you 100%. I mean, patient care should be at the forefront of all of our minds. How can we better serve the community? I get money as an aspect, but at the end of the day, it's about patient care. And we can't lose sight of that.
Well, let me just jump on that real quick, because I mean, this is about patient care. And in terms of those offload times, I mean, we have 15 beds. If 5 patients are waiting for an ambulance to take them somewhere else, that's 5 beds I don't have to receive patients on. And, this is essentially, we're talking about finances. This is cost shifting from the 911 RFP contract to, I hope not just putting this on the hospitals to deal with the financial problems with all these transports, because the hospitals don't have the resources either. I mean, all the hospitals in the county are in the red. We're all having financial problems, and it's going to impact patient care. And that's what the hospital's been quite clear about communicating our concerns. And I hope we can look forward to finding some kind of solution for this. But the hospitals don't have the financial resources to solve this problem either.
I've also been involved in some of the other conversations with CCT transport, behavioral health transport, and the easiest potential benefit I see is with the behavioral health transports and unbundling those from the initial RFP. And I've worked in other counties that I have, cage cars, and it makes sense to potentially have ALS, BLS, CCT, similar levels of competencies with different levels of acuity and training and equipment. But behavioral health is just you don't need the same equipment, you don't need the same medications and the transport vehicles, and I think there's both major cost savings and those are the longer transport times, the longer wait times, and that seems like a low yield place to start the discussion, in my opinion.
Seems like a lot of the behaviorals are CCAH patients, Medi-Cal. Would anyone disagree with me on that? Yeah. So, that's an area that we're going to be addressing with our service. We can definitely help with those. We do those every day in Merced. We take hundreds a year and all over the state. We're going to Santa Rosa, we're going to LA, we're going to Sacramento, multiple trips. Vans going multiple directions just on behaviorals. It's a mental health issue. It's not a medical really issue, as they would say. So they don't require ambulances in order to transport. And like you said, cage cars. I don't like the idea of a cage car. 2 people sitting in front, 1 in the back. If they bang their head on the cage, split their head open, who's liable? There has to be an attendant with them to actually make sure that they're not unbuckling, banging their head on stuff. Because I've been in those transports. I've seen it firsthand. I've seen what they're capable of. But that's definitely something that we could help address with active transport.
So Teresa, you'd mentioned specificity and trying to tie this up. And what I want to find out is, are you stating that you're still taking comments and that you're seeking more specificity? And if that is the case, do they send them to you, or when do you want them? How do you want them? And is that what you're asking?
Chief, so the official public comment ended. And what I was saying is that we were hoping to have had more specificity. That was the point of the public comment period. What we've done is that because you saw how many comments were about certain topics, that we've done some follow-up on those. And so that we're working through those, but at this point, there's no time to reopen public comment to try to get more comments and to get to specifics. I'm just saying, you know, it would have been nice to have had something more specific when we got the public comment period. I mean, some of the comments were very long, but not really giving suggestions for, you know, for potential solutions to an issue. So that, you know, to me, it's just kind of a missed opportunity there. We are working with what we have. We are following up. We are able to have this discussion here because it is an open meeting, a public meeting. That is the advice that we've been given, that we gather our public, that we do this more in the public setting. And that's what we are trying to do. I think that more than anything, I want this committee and I want our stakeholders to understand how difficult this is, what a difficult task we have. We've heard a lot about innovation, flexibility, that we could do better, but we didn't hear how we can do better through the public comment. In November, before the public comment period closed, when we had the meeting with this committee, that 3 committees jointly, actually, we had that meeting, we heard a lot about that. And so I was looking forward to getting the public comments from everybody because I thought we were going to hear some specific things. You know, we should do A, we should do B, we should do C or B. And that was not, unfortunately, it was not the case. So now we are coming up, and what we did here is that we gave you the old scope of work, and there was no innovation and all of that. I wanted you to, I really wanted to take time and do this presentation and focus on some of the areas where we have been, you know, brainstorming and trying to see what is it that we can do, and we're bringing those to the table. And oftentimes we just hear why, you know, something that we put on the table just simply doesn't work. You know, which is fine. If it doesn't work, it doesn't work. But then what does? You know, we have been wanting to hear that, and we had hoped that the public comment period would have led to some solutions, specific solutions from the system, from our stakeholders.
Okay, any other comments?
Thank you again.
Very good. Moving on to behavioral health community crisis services, Deborah.
Yes, we had hoped to have a representative from the Behavioral Health Bureau at today's meeting. She was scheduled to participate in on the previous EMCC date. With the meeting date change, she was not able to make it, so we are working on rescheduling that for the upcoming March meeting. And we're also meeting next week with their representatives to discuss some of the questions that have recently arisen related to community crisis service responses. More to follow.
Okay. Any questions? EMCC annual report, Deborah.
I'm actually gonna.
And actually
I'm gonna
mix that
take
with
that.
the EMS.
Yeah.
Did you want to mix that with the EMS
No,
annual report?
okay.
Okay.
So in the past, the EMS agency has provided an annual report, and it was the annual report that sort of took the place of the EMCC report that, you know, you guys didn't have one. I brought some copies. So what we've done is we now, starting last year, split out the EMCC report from the EMS agency report, and the EMS agency helped take the lead in putting together the report, putting the information together. It was brought to the committee endorsed it, it was sent on to the Board of Supervisors. So this year, we'd like the EMCC to actually take a more active role in the annual report from the EMCC. You will find, I brought a packet, I will email this to the committee so you have it both in paper and electronic. Staff report, it gives, you know, why the EMCC does an annual report. It's required by California Health and Safety Code, the EMS statutes. There's some areas that it's required or that it's supposed to report on. I've highlighted those in the staff report. And then I also provided a copy of last year's report for style if you want to do that or change it up. So this is the first introduction to it. Didn't really expect much discussion other than it's time for the committee to be thinking about how they would like to do the EMCC annual report that will come to the EMS agency and the Board of Supervisors as an advisory report. With that, are there any questions from the committee?
What's the deadline?
I have a comment. Last year was the first time that we submitted a report from EMCC. We couldn't find anything in our records that said that the annual report replaced it or anything. So we were sort of starting from scratch. And yes, the EMS agency staff wrote a draft of the EMCC report, and it was sent to the committee for review and comments. And I think that the base of that was, part of it was the annual report, because a lot of the activities of the EMCC are captured in the EMS annual report. So it kind of made it easier. So maybe that is a way to approach it, that when we bring a copy, the draft of the EMS annual report, that can be used as a basis for the EMCC report. At least you would have something, instead of going back to your notes, going back to the different agenda packets, that you have something already condensed as to the activities of the EMS agency, and that would cover a lot of the actions taken by this body.
Yeah, I have a couple of questions here. So it sounds like you're asking us to create the annual report for 2023. Yes.
It is an EMCC report that's advisory to the agency. So it really should be as much directed by the EMCC as possible. And as
Right.
staff, we're willing to support, that.
So the technical question I have is, we can't talk to each other outside of this committee meeting due to Brown Act issues. So how do we exactly get together to do this?
So I
think we
That's
make
a-
it an
that's a good-
agenda item,
yeah.
break it down and then
Okay.
discuss it.
So
Perfect.
as
So it has to happen here.
right now, you can't, the committee cannot talk about matters that it's going to take action on. That's, doing the committee business outside of the public purview. To come together with items for a report, you can certainly, send them to staff, and staff can ensure that the committee members all see the ideas that, are being thought of to be included. So again, as just some ideas that, you can consider are, sending to me as I'm staff for the committee, your ideas on structure, on items for inclusion, add those things, and then we can distribute to the committee to come up with what we'd really like to do for the report. And again, we've got a meeting coming in March. We'll have much more robust discussion then. And then hopefully by May, the report will be written so that the committee can endorse what we then have for the board, which again, we've been trying to do a fiscal year, so it should go to the board sometime.
Just FYI, this is a requirement of the board. There's a regulation that requires this report to go to the Board of Supervisors, and the Board of Supervisors has also added some guidelines. And the deadline for the report coming from EMCC is due to the Board of Supervisors in July. So by then we will have done our EMS annual report. So I think between the meeting in March and May, the details of the report can be worked out. In July, it can be finalized and then sent to the clerk of the board for distribution to the members of the board.
So what commit, am I going to send these comments to you.
Sure,
Steve?
that's fine. I can collate them. That way I'll have them ready for the agenda for the March meeting.
Okay.
Is there a possibility that, because I'm hearing a couple of things. One, I'm hearing that this had never been done before. And then I'm hearing, and I appreciate and respect that the bulk and the direction of this report should come from this committee, which is correct. But I think due to the fact that it's new, that last year we're kind of dealing with people that may not, myself included in this, may not be as familiar with it. Would it be possible to get copies of other counties' reports so that we can see, in the March meeting, so that we can see what is included in those? And then that gives us an idea as to what we feel is effective and not effective. And if that information can also be included in the board packet or the committee packet in time for review prior to the meeting, that would be very helpful.
So, yes, I'll do a search to see if I can find what other EMS or EMCC committees have done for their Board of Supervisors and their EMS agency. I'll reach out to some of the agencies to see what I can get. The other thing that I'll offer to help with is once you guys get the ideas together, I can help meld it together so it's a coherent, a report that flows and not just a bunch of random ideas all together. So we can help with that. That's, but the ideas, what you guys want to report on, that really should be your ideas.
And we have a template as well from last year's
Yes.
EMCC.
Yeah, that's what I was gonna say, Chief Lamborg. The EMCC committee submitted an annual report to the Board of Supervisors last year. And we used the EMS annual report that we've done every year since I can, at least since I've been here. We attached that as a supplement to the EMCC committee report. So there's already Dr. Burley said, there's already a template. It doesn't go, if I remember correctly, and I think Corinne is online, it does go to the board. So we have a template for the board report that would have to be attached to take it to the agenda. So I don't know. I don't think that we need to survey other counties because they, each does board reports differently and stuff. I think we can look at what we did last year and then just go from there. I think we do have a good template.
I just want to clarify. So I'm just so you know, the perspective of my comment and my questions is basically as a city of Greenfield staff members. So if my governing board, I wanted them to do something or they were requesting something, I realize that to a certain extent, they're going to be relying upon me for a certain level of guidance and even leadership. And that being said, we've done this once. I don't think anybody on this committee member knows because it's not been done before. If there are legal requirements that are supposed to be in there, what's a good thing to put in there, what's not a good thing to be put in there. I realize that we did do it last year. And that's important, but I think I would lean back on the EMSA staff to help direct us so that we can put forward a good report. And I think that's really the emphasis of my comment there. I don't think it's really fair just to kind of look at us and say, well, here you go, figure it out, when, we don't know what we don't know.
Some of that is.
I agree with you there, Chief Lamborg. I agree with you there. And the EMS team is here to support that. We mentioned that last year was the first time that I know that the report was submitted, and that came about from the EMS agency. We told you that we are looking inward as well as outward in terms of ensuring that policies are followed, the regs, everything. And in the process of doing that, we came across the requirement of EMCC needing to submit a report to the Board of Supervisors. And we looked to see if the EMS annual report was back. And we couldn't find one way or the other. And so we started making sure that we followed the rules and had a report from the EMCC committee to the Board of Supervisors, the first one, which was done last year. The reports are due to the Board of Supervisors in July. So we were checking the regs, and that's how we came across that requirement and realized, hey, we better make sure that this requirement is being met, and then we are meeting it to, you know, not only is in the regs, but there's also some language that we were looking at from the clerk of the board that they sent us that guidance. So when we helped the EMCC last year put together this report, we were looking to make sure that we met the requirements of what the report should include.
So in the staff report, there's a summary of the requirements from Health and Safety Code to give you a sense of the parameters that they're looking for, but they don't ask for any specific data points. It's usually the areas of the EMS system, you know, to look at, which is very broad, actually.
Okay, EMS annual report.
And that's fine. So this is the EMS agency's annual report to the Board of Supervisors. We have begun work on this. Historically, we bring it to the Board of Supervisors during EMS week in conjunction with the proclamation recognizing EMS week. So that EMS week takes place this year, May 19th to 25th, which would put us bringing the report to the board on May 21st. So we will work to meet that deadline and more to follow as we develop the report.
Very good. Questions, comments? Okay, announcements for the good of the order. Okay, seeing none, next meeting, the next regularly scheduled EMCC meeting is Wednesday, March 13th, 2024 at 10:30 a.m. and maybe we'll be back in the cinnamon room.
I hope so.
It should be.
Chief, can I ask a quick question? Is there a subcommittee for the RFP? I know underneath, you know, I understand we're trying to avoid any Brown Act violations, right? We have EMCC. However, EMCC can also create a subcommittee or possible work group that's focused, targeted for RFP, because it seems like there needs to be a little bit more transparency and clarification on some of the questions that were presented. You think that's something that might be able to be talked about maybe at the next meeting or further discussion to create some type of subcommittee so there could be transparency with working on that?
I'm gonna turn this over to Teresa, but I just kind of two blanket comments. One, I know that they're coming down to time on it, one. And then the other part is I imagine there's some legalities that are involved in that. And with that, I'll let Teresa answer.
Yes, the advice from County Council has been to do as much of this in a public setting. EMCC being a Brown Act committee is subject, you know, the meetings have to be public. So this is the best forum where we can discuss openly as much as we can the RFP. But there isn't a stakeholder committee that deals with the RFP. The agency works internally or with consultants, but we seek the input in as much input and participation from the system as it is allowed. It is a very regulated process by the state as well as by county council and contracts purchasing department. So we have to follow the rules of those three entities or people. And so we are doing our best to do that. So we bring discussions about the RFP to this forum because it is a public meeting that we agendize. We notice, we have a 72-hour notice on the agenda so that people can, anybody, members of the public, stakeholders, can attend the meeting and be able to participate once we create smaller committees that would not be subject to the Brown Act, then I think we start to run into problems because working, more, I don't know that we would be allowed to create a committee for that.
A subcommittee is required underneath the EMCC to abide by all Brown Act rules. I'm just saying a targeted, specific, okay.
Okay.
Yeah, thanks.
All right, we hit next meeting. I think the only thing left is adjournment. Go ahead and adjourn the meeting.
And thank you all for staying over. Much appreciated. And thank you all for your participation.